As Sean says, we're unique, I suppose, in the UK in that we have acute community care, mental health and GP populations to look after. And certainly the way we have approached our work with Orion is very much on a regional basis for all of those areas. So it really does give us a chance to reach into all areas of the system. What I'm going to do really in terms of the presentation, I know some of you know the background to Northern Ireland, but I am appreciative of the fact that there are some new customers. So maybe just put it into a bit of context. Look at some of the work that we've done over the last year or two, some of the work that we're currently involved in terms of pilots throughout the region, and then what I think is really a fairly transformative roadmap over the next year or two as well. And it is very much a journey and a partnership journey that we have undertaken with Orion over the last few years. Very successful partnership, I think. So the NIECR was very much a case of how do we bring all that information together? And back in 2005, we decided to have an objective to try and build a more integrated platform. We started our research and really then engaged, and I think this has been one of the key successes for Northern Ireland, engaged with a cohort of very enthusiastic clinicians in terms of how we actually wanted to move forward. We got support from our Department of Health, and they provided some seed funding at the time that allowed us to run a pilot exercise in the Ulster Hospital in Belfast. And that was enormously successful with the clinicians, and really it was clinician lobbying that got the project started in a real way. Went live in 2010, and we've added and built to the core product ever since. I just want to touch a wee bit then on where we are. The original business case, we far exceeded the number of users and the level of penetration that we originally envisaged in our business case. We have a wide range of users across all those disciplines. So you can see, for example, very, very high levels of usage among nurses and among our doctors and clinicians. So it's at the moment, it's very heavily acute focused, and really that has been the focus over the last few years. What it has done though, over the last 18 months, we've started to get interest from social workers, from allied health professionals, and indeed even from the independent sector. So we're currently rolling out, for instance, access to community pharmacists, for instance, and that level of stepping it up in community and social care is a big focus for us over the next year. We have a high level of penetration, as I say, in acute at the moment, and you can see there medical and dental, and our GP coverage is very extensive. It's over 100% because we've also counted in the locum population there as well. We have 70,000 staff in healthcare in Northern Ireland, so you know to reach those levels of penetration on the clinical side is very good. And as I say, it's tripled the business case figures that we were intending to achieve. Our logins continue to grow with over nearly 700,000 successful logins alone in September. So looking back over the last year, one of the key developments, and again very much developed in partnership with one of our trusts, the Northern Trust, has been the e-triage process. So for those of you who know how referrals are made in from GPs, it's been certainly in Northern Ireland, it was a very manual, reliant on letters coming in, and it would do a bit of to quote a New Zealand term, a bit of a ticky tour around the hospitals and around the various consultants before they got into the correct outpatient list or the correct consultant list. Slow as well. It could be up to 2 weeks, 3 weeks before referrals actually hit the hospitals. So, you know, when you're sitting as a patient trying to get onto a waiting list or trying to be seen for an important condition, that's a really important length of time. And really what we did was we took the whole process right through from GPs. The referral is now electronic. It comes through to the hospital where it is triaged electronically and is automatically fed in through the workflow process into our patient administration system for the admin elements of the triage, and into the appropriate consultants lists, or indeed the appropriate outpatient booking. So it is a complete process done electronically. So, I mean, the benefits of that are huge, not just the time, but we also create, it's a bit like Parcel Force, the GPs can actually track the referral and see where the referral is, at what stage it's at, and they can then obviously have a better informed view of what's happening to that referral. It also reduces duplicate referrals. I mean, anecdotally, GPs would tell us, we used to get referrals just lost in the system and have to re-refer patients quite a lot. So that has massively reduced the amount of duplication. It's an award-winning solution. It was voted in 2016 the best admin information or data system by the Healthcare Awards. And certainly, as I say, we tremendously successful in the Northern Trust. We've now rolled it out right across Northern Ireland. It's in at least 3 or 4 specialties in each hospital, and we're on target to actually have full coverage of that before the end of the financial year. So massive development. For me, what was a really proud moment was actually sitting listening to a doctor talking about a cancer patient being referred in from the GP, and by the time the patient had got home that afternoon, the referral had gone through a red flag referral. They had got booked into their consultant outpatient, and they had a cancer appointment for that week. Now, this is about saving lives. Every day counts when you have a diagnosis like that. So that we felt tremendously proud that we were part of making that happen. Okay, so that's e-triage. Fully auditable as well, as I say, which is important from the governance point of view. Radiology, order comms, we were getting the radiology reports coming back into the system, and we felt, well, why not start putting the actual orders through the system as well. So that is very, very important. That's happened over the last year as well. One of the key things about that is that in placing the order, we can now actually place for multiple modalities. So if you want an ultrasound scan and you want a CT scan or an MRI, it used to be that those had to be done in sort of separate individual orders. The consultant or the GP can actually place an order for 2 or 3 of those tests to be done at the same time. Again, diagnostics is very often a blocker and a time-consuming thing that stops patients getting flowed through the system appropriately. So the idea that you can order all those things in one order, get the results back into ECR very quickly, has been a game changer for radiology. Again, reducing duplication, because very often what happened was things were ordered, didn't happen, had to be reordered again. So huge cost benefits actually in all of this as well. Regional mortality and morbidity, just tracking. Unfortunately, some patients do die in hospital, and we had a situation where it was a combination of paper letters, various 10 different systems for recording patient deaths. Really not a very good system for actually reviewing. So where there is multidisciplinary teams reviewing patient deaths, that was very disjointed process. So we've actually created that in ECR now, where the death certificate is actually generated on the wards, and that is fed through then to the regional teams who review these deaths and the learning obviously from them. We've stepped that up actually this year, that the coroner's office has actually asked us to send or create a link where we send it through electronically as well, and that's happening, as has the General Registry Office as well. So again, that whole flow right through of getting that information out has improved. Results sign-off. This is a hugely complex area. What used to happen in terms of results sign-off is that lots of these things were generated and printed off in paper, sent up to the wards, and the junior doctors would sit with swathes of these things, signing off, laboratory tests or whatever it was, and putting the clinical signature to it. We've tried to introduce a workflow process there, which actually tracks them right through. The consultants, it's attached to the various consultants, but the junior doctors can sign off at various stages. That has been a hugely complex module to try and work through in terms of the workflow. Again, high levels of clinical engagement in that. Really we're talking about clinical risk here and clinical audit. So very important that we realise, I suppose, that clinicians must sign these things off appropriately, fully auditable as well. Huge gains from a governance point of view. An exciting one for us is the diabetic pathway. We had a situation in Northern Ireland where we had 10 instances of different diabetic systems for both adult and paediatric diabetes. And we took a decision that we would try and work with the clinicians to agree a standard diabetic pathway and to put it onto the workflow capacity in the Orion ECR. That has been a hugely successful project for us, so much so that we've been able to switch off and decommission all those legacy systems. I don't know what it's like in other regions, but trying to agree a standard pathway for anything is huge. You're not just really, we look at it, we tend in the IT community or the business community to think about it in terms of, well, we'll just agree the process. How hard can it be? And you then realise that you're very quickly into areas of power among clinicians as well, and trying to broker that, I don't think is an easy process. But again, back to our clinical content group, which has been at the heart of success for so many of our modules. We have a diabetologist, Roy Harper, who is absolutely inspirational. If you got diabetes, Roy's the guy to go to. And really working with him and a process of iteration. I mean, this has been very much the case with this partnership journey, process of iteration to come to an agreed pathway. Successful pilot, and it has now rolled out into the whole of Northern Ireland. As I say, cost, not just the cost savings, but the fact that we actually have shown now that with a will, we can come and agree together a standard pathway. What that also means is that starts opening up the whole diabetic pathway information in terms of analytics. And we're very much looking forward to, we're doing some EU projects, for example, in this area, and we're looking forward to getting those kind of insights that Ian has alluded to and trying to bring those back in. How do we get those inserted back into the clinical pathway to enable clinicians to make better judgments? I'm not going to talk in detail about those other data integrations, but the slides will be made available. But very happy to talk to anybody who wants to talk to us about any of those integrations that we've done. Big focus for us at the moment is social care integrations. I think Sean alluded to that. So maternity and some of the mental health integrations that we're doing at the moment into the electronic care record. Regional oncology, cancer and haematology as well. Looking ahead into what we plan to do over the coming year, Really interested and looking forward to hearing what Scotland have done. I mean, this is the value really for us of this kind of event, is very much about the shared learning and the shared challenges, I suppose, in what we're trying to do. MedRec, huge risk. This is a big area of clinical risk in hospitals in terms of getting it both at the stage where the patient comes into the hospital and also at the stage where they're being discharged back out into the community. So what, again, clinically led approach, trying to get to a complete view of medications and work with the various workflows throughout the hospital to allow, for example, if there's change in medication, if there's new medications being added, so that the patient actually leaves the hospital with an updated medical record in that respect. But also what's really key about this is automatically being fed back into the GP system, not just in the form of a letter, but actually inserted right into the GP record. So in effect, what we're doing there is closing the loop through from referrals right through to the discharge process. And again, that's very closely linked to the idea of a discharge letter. I don't know how many of you have had relatives or been in hospital where, you get a discharge and then you wait, and you wait, and you wait 10 hours or more for a discharge letter to be handed to you for leaving. And really what we're about with this particular module is trying to create a standardised discharge letter that pulls together information, the prescription information we talked about, the medicines reconciliation, the coding, the sort of plan of action for that patient, pulling it together from the various sources into ECR and allowing the patient. Now, what we again have encountered on that is some difficulties in, for example, just the workflow and getting the clinicians to agree, who does what and who sends what. And that's very much in development stage at the moment. So I'm looking forward to hearing how Scotland have managed to solve some of those challenges. But that is seen to be a very important development for us this year. I suppose one other thing is that for us, we have an assurance standard called GAIN that all discharge letters must meet. So this module will actually be another method of providing the governance and assurance in that particular area. Key information summary. Very often what happens in terms of emergencies, and particularly for long-term conditions as well, like COPD, there's wishes that aren't normally captured in a normal sort of medical record. So for example, in terms of COPD, you might have something that says, if there's an acute exacerbation and it's end of life stage, the patient does not want to go to hospital. They want to be treated at home. So the ambulance service will then need to have that information available to them so that if they're called out, they can actually see, okay, it's on the key information summary that the patient wants to die at home. So though that kind of information is captured, it's created, the key information summary is created by GPs and fed through to the ECR. And it's very much a snapshot of that key critical information available in emergencies and for long-term conditions. Improved communication, again, between primary and secondary care at the heart of it, and really patient safety and respecting patient wishes is very much at the heart of this as well. Sean touched on the cross-border radiotherapy referrals, and that's really us trying to work across two government jurisdictions with very different healthcare systems. What allows us to do that is a health and care unique number that has allowed us to tie the two systems together. And that is really the start of what we see as closer collaboration and access to the system by both sides of the border. Current data integrations that we're working on are theatres, endoscopy, anaesthetic and enhanced cardiology as well. They're all mini projects that are running, starting up at the moment and will be delivered in the next year. Electronic document transfer, I'm coming to the end of this because I could go on and on ad infinitum. As you can see, there's a huge amount of work being done across a range of different things, but this is one I think is worth drawing your attention to. So what we have done here is in our PAS systems, in our patient administration systems in the hospital, we have something called Patient Centre, which stores all the documents that are generated in the system. We are now linking that up with ECR and providing that across to our GPs so that the letters are sent almost instantaneously and in some cases fed directly, populating the GP systems. A few comments on that. Documents received within a couple of hours and not having to send the letters in an internal mail. So it really is this notion of a paperless flow back to the GP system. And it's, for those of you who are techies, I've included the tech diagram on that, showing how that works with our 4 different GP systems. And our benefits really in terms of the comms, audit, reduction in printing, all those sorts of things. But ultimately, really what it's about is about the flow of information to support patient care and making that as fast and efficient as it can be. So next steps, you'll have heard on the news, we're not doing so well in the NHS and in Northern Ireland on ED and our waiting times. So this is seen as very much an enabler to try and get faster throughput through ED and faster discharging into the community. Patient portal, I'm not going to touch too much on that, other to say that we've been heavily engaged with Orion over the last year in trying to look at a patient portal for Northern Ireland. Again, very interested to hear what others are doing, particularly Scotland in this area. We really feel that this is going to be at the heart of patient engagement and giving patient access to their record. We're very excited about the possibility of doing that work this year. We have a Pathfinder proposal in place for dementia, and we have Roy lined up, champing at the bit. We got a letter this week saying, please, please, please go ahead with this. We're thinking of it for diabetics, and we want to roll it out to our diabetic community. So, when you sit and think about it, this is a game changer for patients having access to that sort of information. I've come to the end of those things. The key thing for me, I'm a big Formula One supporter, and I love watching the Grand Prix. And for me, it's an analogy. Patients are on that journey around the track, and what often impresses me is when you see the cars going into the pit stops, and there's multiple people working, and there's lots of information and data, and it's all about getting the patients through those things as soon as possible and out onto their journey. That to me is what we do. We are very much around trying to, have the right information at the right time to allow the clinicians to process the patients on their own personal journey round the track as quickly and as safely as possible. So thank you very much for your attention today. I hope some of that's of interest to you. Stephen and I are about for the rest of the conference if there's anything that anybody has any interest in. Thank you.